entered the profession at a time when women of color were not expected to succeed, much less lead. And yet, she did, again and again navigating through and around obstacles that tested the very spirit of her resolve. Before she became the nursing professor, Dr. Shelia Spurlock walked nearly every path nursing has to offer, from bedside, charge, community health, mobile health, claims, and even the White House. She's walked into homes where families whispered their fears and into hospital corridors where prejudice still lingered. And through every chapter, she carried the same conviction: nursing is a calling, not a job. Today, as a university professor, she continues shaping the next generation with wisdom earned from decades of service and experience. She teaches purpose. She teaches resilience. She teaches from the heart, leaving a legacy carried forward in the hands that she has helped shape. Hands that will one day hold someone's mother, someone's child, someone's last breath. This is one of a series of conversations with a dedicated servant who has lived an extraordinary journey. This is your sit down with the nursing professor.
Well, it really happened very early in life. I can remember 5th grade. I had a journal. My teacher, Miss Taylor, I still can remember like it was yesterday, taught us how to journal. And one of the questions that was asked was, what did I want to be when I grow up? And looking back on that, I saw I wanted to be a nurse and I wanted to be a teacher. And I have become both. So I have satisfied that desire quite some time ago, from 50 years ago, maybe even longer than that, 55 years ago. I could see that this is what I wanted to do. I like to solve puzzles, love to do jigsaw puzzles. I would even do like the puzzle in a newspaper. Of course, nobody gets a newspaper anymore, but I would try my hand at crossword puzzles. So that natural curiosity in me was just easily transferable to taking care of patients. Well, what happened with me, and what I would tell every student is this, is that when you have your clinical experiences, you get some ideas to whether or not this is a profession for you or not. And at that time, in physical therapy in particular, there was a lot of rehabilitation to older people, people who had chronic diseases like Parkinson's and strokes, and it really felt like they were not going to get better. So in today's world, physical therapy is a lot about acute therapy where people do get better. And so you could see some reward as your patient got better. I couldn't see that at that stage back in, I guess that would have been 1982, 1983. Also, along with that, I can now admit I was too emotionally immature to deal with patients. I really, really was. And I think recognizing that was important, because I often tell my students now to really think about it, because nursing from the outside looking in looks as though it's something that's really manageable. The real deal is that some days it's not manageable, and you need to really know how to manage your emotions in order to deal with the day-to-day operations of being a nurse. So yes, when I started to go back to school for nursing, my hands were full. I had a newborn. I had a marriage that was crumbling. Nursing schooling had nothing to do with that marriage crumbling, but it was already crumbling. And so what I recognized was I needed, and this is not a derogatory term in my book, but I needed a tribe to help to assist me with all of the demands, because the truth is, nursing school actually takes a lot. It takes you being available for clinical rotations on the weekends, long hours, studying, group studying, all those things that are not necessarily conducive to a new family and a newborn. So as I was able to recognize I needed more, then I just called in the troops. And so I had people who really assist me. So one of the first things I would tell nursing students is this: you can do it, but you need people to assist you in accomplishing that goal. I think going into nursing school for me was probably the best idea to go into it later. As I mentioned before, I was emotionally immature at 23, 24 to actually deal with the load of taking care of patients. And so at 30, I knew what I wanted to do. I was convinced of that. And there was no other option but to succeed. Was I a straight A student? Absolutely not. I was looking forward to getting that C+ in order to pass the class and not have to repeat it again. But being an older student, yes, you have more responsibilities, but you also have a lot to bring to conversations with your patients. Meeting patients that are ill, frequently they're much older, especially if you're working on med-surg or emergency room, ICU, or any of those areas. And so being able to talk about things that are relatable to them really was helpful, because I was a 30-plus-year-old. I had a child. I had gone through school before. I had worked in other areas before going into nursing. So I was able to have a lot of conversations with our patients that maybe I could not have had at 22, 23. So my first job out of nursing school was at Johns Hopkins. It was on Nelson 5. It was on a neuro floor. So it was very, 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 very challenging. But one of the challenges I could not anticipate was the prejudice, the racism that existed for me being the only RN on that floor that looked like me. I had lived my life in D.C., Washington, D.C., which was at a time, it was considered Chocolate City. And I was used to seeing people who looked like me. My first degree also was from Howard University, which is an HBCU. So in that university, it was instilled in me that we could do whatever it was we put our minds to. So I was used to being around people who were professional, who were able to succeed, and going into an environment where people looked at me differently, like, why are you the registered nurse? Or the assumption of a patient when I came in to see them, I was like, hi, I'm Sheila, I'm going to be a nurse today. And they look at me like, okay, where's the nurse? That soon was quite eye-opening to me. The other thing that I found was staff, my coworkers, really didn't know how to relate to me, the nursing coworkers. And this is something that hopefully has changed in the work world, because we're a little more diverse now, and I think we're about 13% in nursing at this point. So maybe it's not as difficult, but that did present a challenge. Now, what I will say to you is this. Patients who looked like me, some of them were a little leery, because they did not think that this young Black woman could be a registered nurse and in charge of their case. Then there were others who felt more comfortable. And this is when I really recognized that representation mattered. Remember one family in particular, the son had aplastic anemia. He had every drip and IV that you can possibly imagine. And I was always assigned him. Hindsight, I don't know if that was because the charge nurse recognized that I was good to be with him because representation mattered, or if it was because he was a challenging patient and a patient that you wouldn't volunteer to take care of just because he had so much going on with him. Family, it worked out perfect because they felt safe that I was going to do the right thing. Working in community health gave me an opportunity of learning how to take care of patients in their own environment. I always noticed this, is that people don't live in hospitals, they live at home. And so the more you're able to help to correct a patient in their home environment, the better outcome you're actually going to get. Now, with diverse patients, again, I recognize that representation mattered. And so when I took care of patients who looked like me, I could see the relaxation in them. I could see them actually listening and taking in the recommendations that I was giving them, because I knew and I understood things that we could talk about. Culture really does matter. But there was one situation where I had an older person who had peripheral vascular disease, and she had a wound on her foot that wouldn't heal. She had spent time in the hospital. Of course, you don't stay in the hospital until the wound heals, you go home. And when I went to see her, I recognized that she didn't have any heat in the house. And she explained to me that you had to get the wood from outside and bring it into a wood burning stove. I'm from the city. I had never done anything like that before, but I understood the importance of her just being warm and comfortable in the four walls of your house. And so when I would go to see her, it was 3 times a week, I would bring in wood for that fire, that stove, in order to heat her home. Now, was that a part of nursing? In my analysis of nursing, then yes, I think that was just as important of an intervention as administering antibiotics to her or doing her wound care, because without it, she would have been sitting in a cold house. And so that's one of the pluses and minuses of being a community health nurse. Taking care of people in our political environment, people as high as the President of the United States. What I learned at the end of it was people are people first. These jobs, these titles are something that we gather later. And so I think initially starting in that role, I was the chief nurse for the Department of Veterans Affairs. I worked for Secretary Vincent Principi at the time. And so my job was to run the Veterans Affairs, but in addition to that was to be a part of this think tank that would meet in the White House. At the time, it was under the George Bush, who was the son, not the father, George Bush. And we would go there, be at all of the hearings where people stay late at night. They have to have nurses there in order to make sure that the senators and congressmen and the president, everybody is taken care of. What I learned in hindsight was the pressure I put on myself, because being in that role, then I knew I needed to provide excellent care. But that care was no different than what I would give if I was in a community hospital. It was probably a little more prompt, because if somebody said they wanted a flu clinic tomorrow, it's like, okay, how am I going to get these flu shots by tomorrow in order to get have a flu clinic? So were there tight deadlines like that? Absolutely. But at that time, I had a staff of maybe 4 other nurses, and we worked together so well that as the longer we did it, then the more relaxed we came, and the more we really were able to achieve all of the goals without being so tight. Because you can only imagine when you're taking care of a senator that comes in for an allergy shot, then you're a little bit nervous. You're just like, oh my God, that is Senator so-and-so, and he's here for an allergy shot. And you've given thousands of allergy shots, but you get a little bit nervous. But it did subside over time, and I recognize that people are people first. I don't remember many occasions where people spoke to the medical staff like out of term, like angry or saying something inappropriate. I don't remember that. So what I currently see by looking at the political atmosphere is really, really something to see. I never lost a patient. I am very proud to say I've never lost a patient. And I believe it's because I have incredible assessment skills, that I pay attention to the smallest things. I can be in line at a grocery store and I'll look down and I'll see somebody's leg swollen. I immediately think heart failure. That's just the way my mind actually works. And so with that, I don't want to be misled and say none of my patients ever died. What I'm saying is this, is that if they came in the emergency room and I was able to assess them, then I was able to get them to the next level of care. Or if I was taking care of them on the floor, I could assess them and say, oh, wait a minute, this ain't work, this not right. And I could call to get somebody to come and see the patient and again, get that patient to the next level of care. If there's anything I can impress upon nursing students and nurses, was using the nursing process. And the acronym we use is ADPI. And remember, that is assessment, that is diagnosis, that is coming up with a plan, intervention. Interventions means actions, and then evaluate whether or not it worked or not. If it didn't work, then you need to do something else. And so, although it sounds like it's 5 steps, it's so fluid when you actually have it in use, because as you go to evaluate whatever it was that you're doing, whether or not it is giving an injection, hanging an IV, doing wound care, any of those actions that we actually do on a day-to-day basis, if you see that's not working, why would you continue to do the same thing? So in the evaluation process, then that's when you determine, this ain't working. I need to reassess and I need to come up with a new plan. I think the hardest single aspect of being a nurse, especially a nurse today at any level, whether or not you have graduate degrees or not, you just graduated from school and you have your RN degree. I think the hardest thing is that when you graduate and you first hit the floor, most times you're going to feel like you know nothing, because taking care of people moves at a rate of speed that can really blow your mind if you're on the outside looking in. My best advice is to get in there. Anytime you see something new going on, if you see that there's a code or someone crashing, say, I'm new, can I come in and take a look at it? Because believe it or not, we learn so much by actually seeing and doing things versus constantly just hearing. And we know in today's world, since COVID, then clinical experiences are sometimes not what they were prior to COVID, just because of the safety that has to be put in place with our patients, because we would never want another outbreak to happen and a student be involved in carrying a virus from patient to patient. So there's some stop guards that have been put in place by hospitals when it comes to educating nurses. But if I were to say the best thing that you can do is to recognize you don't know everything, but you are there to learn. And people should be patient with you. And I'll say this to older nurses or nurses who've been practicing for a while: stop eating your young. We need to nurture them. We need to remember what it was like to start out, and such that we give them the time necessary in order to grow in their craft. They didn't get through nursing school just because they were liked or that they had some frivolous experience. They got through nursing school because they earned it. But we, meaning the preceptor, the nurses on the floor, when a new person starts, you really can make or break their career. Oh, I hope students carry with them when they leave my classroom that patients don't live in hospitals, they live at home. I want students to continue to build their curiosity so that they can help solve some of the problems that they will encounter. I want students to become active in professional organizations such that their voice can be magnified. I think frequently we have a lot of talks and discussions about what's wrong in healthcare, what's wrong in nursing, because it gets a lot of likes. On the internet, gets a lot of likes to bring up those exceptions to the rule. But for the most part, most people are receiving safe care. And nurses are behind that administration of safe care. So I want my students to understand that don't be so dismayed about what you actually see on the internet about a person did something wrong, because usually that's such an outlier. That is not going to be you. And if you take the information that you see, then you say to yourself, I don't want to be that person that did the wrong thing. And so I hope my students go out there, maintain their curiosity, treat people as though they're human beings, regardless of what their station in life is, and to really take care of themselves, because it's really, really just as important to take care of yourself when you're in healthcare.